How do we deal with it, sir?
So basically, see what happens.
And sir, I want to know more about that structure, why it happens, and the
I'll tell you. I'll
things
tell you
about.
that. I'll tell you that. I'll tell you. See, you are having any joint involvement. The arthrokinematic reflex gets altered. Okay. So when the arthrokinematic reflex is getting altered, so there will be relative muscle spasm structures in and around that area will go for some protections, right? So thereby some lymphatic accumulation will happen. So over a period of time that lymphatic accumulation becomes hard. Once you go for the mobilization center, that will get dissipated. No, you need not. That is a secondary manifestation, so you need not do anything directly on it. You go for the joint mobilization, you just experiment, you go for the joint mobilizations, do the specific managements, as we discussed about the identify the problem, do the specific management, that will naturally go. If it does not go, you apply little bit of MFR, myofascial release, it will go. Now, we'll restrict it to this.
Thank you, sir. Thank you so much.
We will give opportunity for others. Oh, yeah, please.
Sir, how to differentiate or identify force closure and form closure? Differentiate and identify.
Yes, fine. Sit down. See, the essential balance of the pelvis is maintained by both form closure and force closure. Okay. Now, if you get any dysfunction in the form closure, now suppose there is anterior rotation dysfunction, automatically it will imbalance the force closure component also. So both are related. Force closure dysfunction will lead to, now suppose force closure dysfunction, one is a lower cross syndrome, for example. Okay, can you please come? Stand here. A lower cross syndrome where erector spine is tight, turn like this. Yes. Iliopsoas is tight, okay. Abdominals and gluteals are weak. So a force closure problem is also leading to form closure issue. So both are related. How to manage? Okay. Now we have to manage the passive component first, because that is the more fundamental component. Maybe I will explain it little bit more elaborately from a biological perspective. Now, in class, I don't know when we started reading the kingdom classification. I mean, maybe class 11th or maybe 10th, I really, maybe somewhere before 11th we have studied that. Broadly, the classification of living organisms. I think in class 6th, 7th we study living, non-living and living classification. How the classification goes and why passive component first is the explanation. Okay. Now, you see you have got Linnaeus classification or Whittaker classification, right? Now, living, non-living, one. We are in living category, no doubt about it. Plant kingdom, animal kingdom. In animal kingdom, broad division. How the broad division in animal kingdom is? Vertebrates and invertebrates. Fundamental classification. So first position in animal kingdom for us is to be a vertebrate, to have a skeletal system. Okay, that is the fundamental requirement in a biological classification. So passive component comes first, right? Correct the passive form closure component, passive components. That itself will restore some amount of the force closure components. Then you can work on the force closure like core stability programs or METs, techniques what we discussed. Is that fine?
Sir, if the problem arises only due to the force closure, so how to identify that?
This is, I told you, no? This is one example of force closure, lower cross syndrome. One example. You want to identify iliopsoas tightness. Go for the Thomas test position, TFL tightness. All these are all related. Or piriformis syndrome we discussed, na? Right? That is one force closure component. Okay?
Thank you, sir.
Okay. Any other question? Oh, last, yes.
Can I ask something? Yes, sir. Sir, can I ask a question, sir?
Who?
Myself, sir. Can I ask?
I'll give opportunity, but you know, last benchers always first chance for question. Huh? Please, I'll allow you. Last, yes.
Hello, sir.
Last, that boy who's standing there. It is always nice to
Good
hear
morning, sir.
questions from, yes, good morning.
Sir, my question is, inominate there is can be combined as up sleep and up player, in player or out player. So, what structure should I first treat? Is up sleep or in player or
Yeah,
out?
very good question. Fine. Well, question is, his question is very nice. What structure I will correct first? Now, out of these dysfunctions, say up sleep, down sleep, anterior rotation, posterior rotation, out flare, in flare. Now, one thing, suppose you have got up sleep, you cannot have down sleep at the same time. You understood that? Because either it has to be up or it has to be down. So, one is present out of it. Now, suppose you get a combination of up sleep, anterior rotation and out flare. What I will correct first? First to correct the sleep dysfunctions. First sleep dysfunctions correct, next correct the rotation dysfunction, next correct the flare dysfunction. That is the sequence of management. Now you don't question me, should I correct out flare or in flare first? Because only one will be present. That question also can come in mind. Okay? Sir told about whether what should I correct. So sleep correction, rotation correction, flare correction. Somewhere in the middle who want?
Yes.
Please. Please give him. Yes.
So one of my doubt has been cleared, sir. I want to ask the same question.
Same question. Very
Yes.
good.
And so another question is there, sir.
Backbencher.
Thank you so much. You asked my question. So another question, sir. Most of the time I come back to so many patients who are having chronic back pain. And what I've learned in theory that in chronic back pain patient, they're having segmental stability loss, weakness of multifidus muscles. So, sir, can you please say me some exercise techniques to strengthen those?
I have already shown.
That's the bracing technique.
Those are also for both. But
Okay, sir.
for transversus also and multifidus also.
Both for the.
But
Okay, sir.
specific, suppose multifidus you want to recruit, you can do one.
Yes,
You just palpate your multifidus. Palpate from midline. You do it yourself. Yes. Anybody else want to do can do it. Now from the midline, half inch lateral you palpate. Which is multifidus is a deep muscle. It is called as multi means many. Many fundus means it has got many stomachs. So that's why it's called as multifidus. Okay. Multifidus is a dynamic stabilizer for the spine. Number one. Dynamic stabilizer, what are the important dynamic stabilizer and why we give importance on dynamic stabilizer? Also I will add here. Now dynamic stabilizer for your spine is multifidus. Dynamic stabilizer for the shoulder is subscapularis. Dynamic stabilizer for the knee is VMO. Now you understand, we have read from the beginning in any physiotherapy practice that anybody with some knee pain, we give static words. So static words is nothing but it is designed to activate your VMO. Shoulder rehab, subscapularis. Okay. Back rehab, multifidus. So when we do the core activity, I told you that tabletop, okay, or all four, and taking it for extension. That gluteals and will spine, it will activate the multifidus. You stand, you palpate from the spinous process about half inch lateral, palpate deep, okay, and then stand on single leg and then take the hip towards extension. Do you find a contraction there deep in? So that is the initiation for contraction of your multifidus. Okay.
Hello. Namaste, sir. Sir, in case of spondylolisthesis, if is a case of 40 years old female, spondylolisthesis in L5 L1, always we go for the flexion exercises, mostly for the management. So what happens is in the long run, extension dysfunctions occur. Matlab, we cannot restore or maintain the extension range of motion. In order to maintain at least extension, what we should do?
See, sit down. If it is spondylolisthesis, which grade? You remember the grade?
Yes, sir. If it is around, sir, 50%, grade 2.
Okay. See, comfortably, if it is a grade 1, then it can be managed, this thing. And if it is remaining from a long time, not getting corrected, then next step is to, and any neurological deficit is there?
Sir, commonly neurological defects, they,
No,
they
you are
present.
asking about a specific, about one case, no? That's what I'm asking you.
Yes, sir.
If
In
you
my,
ask me in general, that is different. I can give
sir,
a
in
general
my
answer.
clinical setting, what I get, like patients, they are complaining of the radicular symptoms also. So in that case.
Okay. No, if you are asking me in general, you understand, no? You told me specific about the lady, no? That is why I have to focus.
No, sir.
We have to be careful
In one
because
of the doubt.
you have to go and apply the technique on that person. If you ask me general, generic, I can give you a general answer. So you want to answer me in a generic way?
Specific and generic both, sir.
No, specific means I have to study that because you try to understand. Because as it is a spondylolisthesis case, you are asking me specific about a lady, so that we can discuss separately. So let me tell you about a generic management.
Sir, generic
okay?
way,
Generic what you
post
have to...
pre-menopause is females.
No, that is a specific, you try to understand. Because if I should be responsible in answering about that condition. So I'll tell a generic management, okay? So that specific we can, so I showed you one MET for the anterior rotation dysfunction. That technique you can apply. That will be also helping in the spondylolisthesis. Plus positionings you have to do. One is passive component correction should be your priority, okay? Now put one pillow under the abdomen so that, you know, it is, that 3-point principal pressure you have to work on. You understand? It is going this way, no? Anterior slippage is there. So we are going for flexion exercises. In addition to flexion exercises, you can add the MET for anterior rotation dysfunction. So that will be also helping to restore the alignment. Okay. Plus, above that segment, because since it is a hypermobile segment, suppose it is at L4, L5, listhesis is there. So L2, L3, you are bound to have restrictions. Okay. So you can give some transverse glides there. Never apply any PA glides. Apply the transverse glides. Preferably, you can put the person under a pillow, under the abdomen, and give transverse glide over to the affected segment or below to the affected segment. Plus add the flexion exercises and add the MET for anterior rotation dysfunction. Right. Somebody wanted to ask something.
Hello, sir. My question was, whenever we have corrected the symptoms or the dysfunctions over there, what will be the program of exercises? Should we focus on the weaker group or the course? What should be the proper exercises?
No, this already long back. I don't know. I think you joined late in the program. I think. No. Because about this point I already discussed initially. But I'll again answer your question. Now he is asking about how do I approach if I am having different types of muscular weakness and tightness. So while I was talking about the lower cross syndrome, about the contribution of neurologist Vladimir Janda, I'll just repeat that. Janda talks about that when you have got these muscular imbalances like a lower cross syndrome where erector spine is tight, iliopsoas tight, abdominal is weak, gluteus is weak, fast, wiser approach will be to stretch the tight structures at first. Stretch the tight structures at first. Then strengthen the weaker structures. Okay? You have to stretch the erector spinae, go for the MET techniques of erector spinae or MFR techniques, MET or MFR technique for iliopsoas, right? Then go for the core stability programs. Specific gluteal exercises or specific abdominal exercises. When to progress? One is this. Next is when the symptoms have reduced about 60-70%, then go for exercise programs. Okay? Start with find out whether the person is doing any exercise or not. If person is not doing exercise, first step I tell, early morning, fast sun rays, you go and sit first for 20 minutes. Because कोई उठ नहीं रहा है पहले उसको जगाना है. And you know we are all solar powered and exposure to sun is very, very important for all of us. So first step, you make sure that you are putting all your patients for a early morning sun exposure, and then slowly you tell, go and sit, then you tell that go and stand, go and walk, then go to the ground and do some exercises. Correct? So that is how you can add. You are not wanted to ask something? Somebody wanted to ask here, no? अरे ठीक है पचारा थिला ना इटी हाथ पात के उठे थिला इटी you wanted to ask, no? This, you okay? Any questions? This is the last question. Then I'll do one or two techniques demo. I forgot to mention here. Yes, please.
First, thank you so much, sir, for in detailed explanation of SI joint management guidelines and treatment strategy. So, on behalf of that, I have a question. So,
Yeah, please go ahead.
sir, you have discussed the management techniques of different dysfunction, common dysfunction about. But how do I differentiate or examine each of the dysfunction separately, and what will be the defining factor for all of this condition that is correlated with the SI joint pain?
See, I think I have to again repeat the entire session. I have discussed everything in maximum detail. You understand? It will not be possible to explain right now.
Sir, you have discussed about the Gillette test, that is
Not
direct.
Gillette test. I discussed about what is off sleep, how to identify off sleep, how to do the management, how to identify down sleep, how to identify rotations. So, I think you are asking me to repeat everything. So,
No, sir.
when you joined, what time you came?
9:30.
So 9:30 means you would have attended all.
Yes, sir.
So
I haven't got that answer. That how will I differentiate all of these dysfunction?
It is quite pretty easy. You see, if say iliac crest is up, ASI is up, PSI is up, it is off-sleep dysfunction. You see, ASI is down, PSI is up. It is anterior rotation dysfunction, right? So I think you need to brush up more. Okay, fine.
Okay, thank you, sir.
Yes. So now lie down supine. Now coming to the pubic symphysis dysfunction. The pubic symphysis dysfunction very common for, if you are seeing athletes, very common for athletes like runners or post-delivery. Post-delivery, this is quite common. Okay? Now, many female physios are there. I'll suggest you to take up or start one unit if you are running your clinics or any hospitals you are working. Try to take up specific session on women health. Okay? And then you go and talk to the gynecologists, because many elite females also, people who are in very well off in the society, when they come after delivery, they have not done any exercise programs. One, cesarean followed by another cesarean, and nearly 8-9 years problem, they are facing problems, and that kind of cases I get. And that too not ordinary people. I mean, they're from very good society. So what is happening is there is not proper awareness about a proper exercise program after delivery. Okay? So that area is one of the major area where we can do and contribute substantially as a physiotherapist. And again, I will suggest you that it is a time where we have to cross-fertilize ideas. Not that we are here and then we listen to each other. No, it is a time when we collaborate with people who are doing, now, sir, you are from orthopedics, right, sir? Medical officer. Okay, fine, sir. So, fine, that's okay. Now, you see, now, there is ankle and foot society in the world. Lot of specializations has happened. And there are there is a requirement for physios who are working ankle and foot. Similarly, hand rehab. Similarly, back care, because now the profession and healthcare practice has gone to very specific regions, right? Now, if I just ask you that how many dental specialties are there, do you know? We are from healthcare, but you may not be able to know that exactly how many specialties are there. In cancer rehab, there are so many specialties, right? I mean, in dental, pedodontics, prosthodontics, this thing. So there are so many which you may not be aware. Certain things you may be learning in manual therapy. You get a skill. You don't expect that other medical professionals will know about it, provided you go and discuss with them. So whenever you get opportunities, you go and discuss with. It is a time where we have to, work in synchronous with other healthcare experts. So somebody who is doing a back surgery, you can go and discuss with them, because everything cannot go for surgery. Or a patient comes, patient might not be ready for a surgery. So that is how you can, we can work in collaboration. This is an era of collaborations, right? So think of maximum collaboration, what you can do. Okay, now ergonomics is a great area. Now whatever we have discussed, that also comes in that domain, because field is open. And compared to the number of professionals we have and number of people we have in the country, we need a lot of work further to be actually done to reach to the society. Somebody wanted to ask something. Okay, now coming to pubic symphysis dysfunctions. Now, what happens? What is the presentation? When there is pubic symphysis dysfunction, there is a tenderness over the inguinal ligament. Classical presentation, inguinal ligament tenderness is there. And that tenderness will compress the lateral cutaneous nerve of the thigh, leading to dysesthesia in the upper medial aspect of the thigh. Okay? Patient is coming and telling that I am getting some vague sensation and I am getting some tenderness here. Okay? Now, very common for athletes. Sometimes there can be iliac strain also, that is okay. Now, the adductor longus muscle is attached to the opposite side pubis. Left side adductor longus is attached to right pubis and right is attached to left. It is crossed. Okay? So in these dysfunctions, we are going to use the adductor longus force to correct the pubic symphysis dysfunction. Okay? Very, very useful and very safe technique. It is like a balancing technique for the pelvic complex. You treat any pelvic complex issues, at the end you can add this. Okay? Now, spread the knee about 1 foot distance. Okay? Ask the person to bring the knees together. Bring it to the midline. Gentle force. 1, 2, 3, 4, 5, 6. Fine. See, the adductor longus of both the side is pulling. And you just imagine, when suppose there is a dysfunction, what is the kind of dysfunctions happen? It can go for antero-superior dysfunction, antero-inferior, posterior-superior and posterior-inferior dysfunctions. Now when the adductor longus will contract, so that balancing will happen. So it's a balancing technique. It is called as adductor pubes. The technique is called as adductor pubes. Okay? Very useful technique. Bring the knees to the midline. Bring 1, bring it little bit more force. 1, 2, 3, 4, 5, 6. Now this technique, you see, there is a Pilates ring. Okay? That ring is coming. So with that ring also, this exercise can be facilitated. Okay? Now this is, now suppose you are doing a upslip correction or you are doing anterorotation correction. After this, at the end, you can add this. It's a balancing technique for the pelvic. Technique management for pubic symphysis dysfunction. Now come to prone line. Prone. Put the pillow, get up. Pillow is kept under the abdomen. Okay, lie down. Okay. Next is, in lumbopelvic rhythm, we discussed about when you bend forward, lumbar spine moves fast, then sacrum, nutation, then innominate, anterior rotation. Coming back, we innominate, sacrum and lumbar spine. Now, suppose there is excessive nutation. Sometimes in lumbosacral angulation will be disproportionately increased. There will be some kind of grooving. Okay. So, there is excessive nutation, excessive sacral nutation is there, and that may lead to coccydynia. That may lead to coccydynia because inappropriate force is coming there. So, a coccydynia case, what are the important management I am just telling you now, or sacral dysfunctions. Sacral excessive nutation is there. What we have to do? And excessive counter nutation is there. What we have to do? Okay. Now, subject is in prone lying position. To the base, if it is excessive nutation, apply the technique to the apex. It has gone this way. It has gone this way, increasing the lumbosacral angulation, more stress coming and it is causing the pain there. In addition, there is coccydynia, coccyx pain is there. So, sacrococcygeal joint is a syndesmosis variety of joint. We discussed in morning. Okay. So, sometimes some fall also can create some swelling of the ligament and that also can cause pain. So, that can get displaced, falling and displacing to left or right or to front. Okay. Now, if there is excessive nutation, what you are going to do to the apex? Apply the technique antero-inferior. Apply the technique antero-inferiorly to the apex of the sacrum. Mobilize and you can give a thrust also. Okay. I will be showing one thrust technique also for that. Sacral, if it has gone for more nutation. Gone for more counter nutation. It has gone for counter nutation. Base has come more posterior, superior, apex, antero-inferior. So, in that case, to the base, apply the technique. In case of excessive counter nutation. Excessive nutation, apply the technique to the apex. Excessive counter nutation, apply the technique to the base. To the base, pisiform, force is applied antero-superior. And overall, if you find the sacrum is bit more posterior, you just see that it's unusually little bit more posterior. So, to the mid part of the sacrum, give the force anterior. You can mobilize and at the end you can give a thrust. Right? So, this is about the sacral dysfunction. You come to side lying position, on your right side. Right. Okay. Now, come front. Straight. Bend it. Relax. Okay. Now, suppose there is excessive nutation. So, mobilization I showed you. I will show you now the manipulation technique. So, hand is kept behind. Make the lumbar lordosis straight. Palpate the lumbosacral joint. Pull from the arm. Once you feel the movement, just stop segmental movement, you stop there. Stabilize. You can support the L5 spinous process. Ventral aspect of the forearm is kept at the sacral apex. Relax. So, take up the slack and give a thrust there. Give a thrust. Okay. Thrust is applied again anterior and inferior direction to the apex. Right. So, this is the thrust technique for the sacral dysfunction. Right. Come to prone lying. Coming to the coccyx. Get up. Right now. So, to the coccyx, you just palpate. You have to see that, as I told you before, prior to this, you have to see the sacral alignment. If it is excessively nutated or counter nutated, because it is going to affect the coccyx position. Okay. First, you have to correct that. then you just palpate the sacrococcygeal joint if it is tender. If you need to mobilize the coccyx, you have to give a force anteroinferiorly. Okay. Now you see that it is bit more left side oriented due to some fall and all. Give a glide to the right. Because it is a syndesmosis joint. Sometimes it is stability by the ligament. Somebody falls, so it may slightly, inclined or twist to the left or a twist to the right. If it is tilted to left, give a glide to the right. If it is tilted to right, give a glide to left. Okay? So, next, a chronic, you find this excessive nutation or somebody was asking about chronic low back pain. In those cases, the dura also gets tight. Sujata madam was doing some research work on scoliosis. Madam, your PhD, no? Your PhD work on scoliosis, right? So, during that time also we discussed about this component. See, just imagine you have seen that bow and arrow, the bow, you take one flexible stick and you twist it, right? You pull it, it will bend. Now you just imagine it is tied to one wire, okay? Now it is, pull it, it bends. Now similarly, now suppose we are tying a rope here, you imagine that is the spinal cord, that is the neuraxis. So if your neuraxis is tight, spine will bend and that will lead to scoliosis. So you just need not focus on the segmental aspect. Okay. Now you need to see this also, because scoliosis is there, definitely the neuraxis is going to become tight. The dura will become tight. So you need to work on it. Not only you have got a scoliosis, convexity, say in the right side you are going and positioning, giving a glide or asking the person to hang, and that is fine. You have to look into this also. Sometimes the neural component, if it is tight, it will lead to scoliosis, and you can do this release technique, okay? Because in chronic pelvic complex issues, you will get this involvement. You put your hand at the occiput, other hand at the sacrum. He has got a bit tightness. Huh? So you go to the barrier, right? Apply a force from the occiput, superior and anterior force, and from the sacrum apply a force, anterior and inferior force. Okay? So if you have got a scoliosis in the right side, you have to turn the head to right, so that the neuraxis of the right is going to get more stretched. So if you are getting cases of scoliosis, along with your regular management, you add this and give me a feedback, right? You can write a feedback. Okay. But any other questions? Any questions? Anybody is having a low back pain among you? Okay. Can you come? Yeah, you also. Who raised hands first? You, one boy and one girl. Fine, come. At present, you have the problem? Maybe if some others, those who are having back pain, please come. Seats are vacant. You can sit here. We'll see if you can take you. Huh? Right. Those of you are raising hand, you are most welcome to come and sit here, so that we can call and take you up. Fine. Madam, pachariva
Just
question.
I want to
Okay, madam,
add
want
something.
you can sit down.
Regarding
Be
the
comfortable.
head position, you told to stress the dura. Like if the scoliosis, suppose there is a convexity towards the right, there can be a compensatory scoliosis on the left side, in the above,
Yes,
like
yes.
cervicothoracic.
Yes.
And down also there can be a compensatory
Yeah,
scoliosis.
most of the cases,
Yes.
it will be like this.
Yes, but some of the cases there can be a single thoracic scoliosis starting from the cervicothoracic. So in that case, if you turn to the same side, there cannot be a stretch. So you have to stretch to the.
Yeah, we can, anyhow, we are going for a little bit, the stretching of the dura, there is no harm in stretching both the sides.
No, like because there is a rotation in scoliosis, there is a vertebral rotation.
Oh, madam, see, I'll tell you, my explanation was related to the attachment of the dura.
Yes.
And you said the dura,
Yes, if-
one minute, madam, let me complete. You see the dura is having firm attachment to the foramen magnum, to the C2, to T4, to L3 and to S2 regions.
Yes.
So what I told is particularly in relation to the anatomical attachment of the dura.
Yes.
Okay.
Yes.
So my what I said is now you are having a scoliosis in the right side. To effectively stretch, because it is attached to the foramen magnum, we need to rotate to right so that the liver, the length is becoming, the tension becomes more in that particular side, considering the morpholo-anatomical attachment of the dura. That,
Yes, when there is a skeletal rotation, vertebral rotation, you have to correct the vertebral rotation.
yes,
then
exactly.
only.
No, madam, that is what I exactly said. Whatever you are doing, that specifically management has to be done.
Yes.
Along with that, this has to be added, because if the dura is tight, that's what I explained. If the dura is tight, definitely it is going to contribute to the bending.
Yes,
also.
that will, along
Yes.
with the skeletal
No,
correction,
I never
that
said
will.
that this is the only management for scoliosis. It will
Yes,
be
yes.
one. It will be
Yes.
one additional management.
Yes. That is again very specific. It has to be very specific according to the curve direction and according to the curve
Yes.
position.
But it has to be added.
Yes.
Yes. Thank you, madam, for your input. Yes. Okay. Any other queries? Huh? Bilateral.
Do you come across bilateral involvement?
Yes.
And then how you take care of it?
The bilateral involvement for the
Yes, sir.
bilateral involvements are rare,
Yeah.
but in general, suppose there is, there is a lower cross syndrome. So both the side we are going to get the anterior rotation. Suppose in bilateral lower cross syndrome. Otherwise, most of the time it is unilateral involvements. But bilateral can be there. Like frozen shoulder, for example. Bilateral, patient will have alternative. Once 3 months back, I had problem in left, that has become better, I have got in right. So you will get right side more, but some involvement in left also. So like that. Sanjay sir, want to add something? Maybe some experience you want to add?
The way you explain the things, everything is clear. Now I was talking to Deepak. When we see patient in clinics, we never go so deep. We treat the patient and make the patient kemti nagala, bol nagala. If you are fine, go home. We never put our brain so deeply. What is going on and what is the past. And that experience will teach us you everything. So going to the depth of the thing is people like you. We go on the superficial thing and we see whether patient is getting benefit or not. So thank you very much. Your thing is very nice.
Thank you, Sanjay bhai. Bhaina kichh kohibe? Deepak bhaina. Always a pleasure. Many sessions we have taken together.
In fact, it's always a pleasure to listen to you all the time. And whenever I listen to your lecture, I always gain or learn something. And today again, I adopted few things from you from the sacroiliac joint. Lovely, beautiful lecture, and always a pleasure. If maybe I would have slept comfortably, but when I came to know Umasankar is taking the class, मैं फटाफट तैयार होके आ गया. नहीं तो मैं शायद कहीं घूमने निकल जाता. Thank you very much.
Many times, actually, Deepak sir and me, we have taken a lot of sessions together. So it is always a pleasure, and any time I organized any conference and all, every time Deepak sir was there. And sir has also invited to me to Capri Institute. I have invited to him to Manual Therapy Foundation. So there may be a general perception. Sometimes they think that we are having competitive organization and all, but it is never. Because not only two, if there are 30 organizations also in a country like India, still it is less, I can tell that. So
Here I can add something, because the youngsters are sitting. Many times you think of starting a clinic and you try to look for an area where there is no clinic so that you can run the clinic comfortably. अब मैं आपको एक चीज़ बताता हूँ, सबसे ज़्यादा सब्जी मंडी में बिकती है, सबसे ज़्यादा कपड़ा क्लॉथ मार्केट में बिकता है, सबसे ज़्यादा ज्वेलरी जावेरी बाजार में बिकती है. So make sure you open a clinic where the medical hub is there. So without any effort, you get a lot of patients. So when me and Uma Bhai is there or many other manual therapists are there, that increase the awareness about manual therapy. More people look for manual therapy. इतनी population है, इतना काम है हिंदुस्तान में, thanks to the hard work done by the parents in day as well as in the night time. So the population is increasing. So there is enough business, enough opportunity for everyone to work. So कभी एक जगह तो आपको काम करना पड़ेगा. If there is no other clinic, then you have to work hard for spreading the awareness. And if there are more clinics, you have to work hard to fight the competition. बिना मेहनत करे नहीं होगा. You decide कहाँ पर मेहनत करनी है आपको. So that way we are complement to each other. जब ये कहीं आग लगा के हल्की सी चले जाते हैं, they want to learn more. या मैं कहीं आग लगा के चला जाता हूँ, they want to learn more from him. So it's always, we always share students with each other.
Always.
Yeah,
Yes.
Thank you so much.
Because I always tell, see, in human civilization, yesterday we had our alumni meet, we missed Deepak sir there. I think you came later, we came to know. But we are all searching for you yesterday. See, if you see our KG days till today, in our KG also, is there a single teacher in KG? Is there a single teacher in KG days? When you go to KG, LKG, UKG, KG means not kilogram, LKG, UKG I am talking about. When you go to LKG, there are also 5-6 teachers who are taking care of you. Correct? I never remember any place where there was just one teacher or something. So, similarly, we should keep learning every time. There are always opportunities to learn. Even when I am standing here and I am talking, I am also in a process of learning because mind neurons are working in that line. Okay? So, Binay sir, kuch add karna hai? You have been a great clinician, doing a great job. So maybe Tanmay is also doing good. Yes.
No, as I told, like yesterday we were hearing to Surajit Chakravarti. As you know, there are many gems which Nirtar has produced, and it is always blessing to hear you all people. This has been a great, like yesterday also I told now when I saw this 1.5 hour session and all, मुझे लगा कौन बैठेगा बंदा ये होगा वो होगा. But the way you are delivering it is getting like everybody is getting benefited, and it's always pleasure to be at the place where our alma mater is there. And as far as the clinical experience of dealing with patients, of course we do come across patients, and as Ram sir correctly told, many a times we don't have time to put our brain into it, but experience, of course, like listening to people like you and Deepak sir and Sanjay sir, of course we are forced to put brains, and our brain becomes sharpened to realize things without much getting into it. Thank you for this.
So
Hello.
I think with the experience of Sanjay sir and Binay sir, I can just tell, although told that we are not, it is like when you are early phases of driving, सीख रहे हो.
Hello.
So that time you have to focus so much कि ये clause लगाऊं, ये लगाऊं, वो करूं. But
Hello.
when you have become a, who is talking?
Sorry.
हाँ? कहाँ से? आवाज कहाँ से?
I'm trying.
ଆଚ୍ଛା ଆପଣ ଟ୍ରାଏ ଆପଣ
ହଁ ହଁ
କହିବେ କିଛି
ହଁ କହୁଛି
ଗୋଟେ ମିନିଟ୍
ହଉ ସାର୍
ମୁଁ ଭାବୁଛି କିଏ ସରୋଜ ଭାଇନା ଅଛନ୍ତି ଆଉ ବଢ଼ିଆ actually when you become a seasoned driver you are not, you are listening to song also, this also, still you are driving and you are driving effectively because you are already one effective driver. Okay, so now when you are treating spontaneously and people are getting result, that means you are already a seasoned and properly trained skilled physio. So that is how it is working by default. Okay, so I mean, but always in every field there is always sky is the limit. I mean, if when Albert Einstein was revered a lot, he gave an important statement. You see, from the various sand particles near to the ocean, I have only picked some. I mean, that is a statement from a great person like Albert Einstein. Science is so vast, and if really somebody has to tell me how much really I understand science, I will tell that may not be even 1%. I can be very candid about it, because till now the knowledge of a cell, the pluripotent cell is also not known. The volumes of books on cytology, but till now we are not able to create a cell. Even if we create a cell, we cannot make it pluripotent. Our life starts from 6 micrograms and then we evolve and teeth come and this thing and hairs, I had last time more hair, now going down. So it is a process and then cytology is not understood. So more complex is the tissue system, organelle system. So I think if you ask me really candidly, I will be very humble to tell that I even don't know maybe 1% of this vast field of manual therapy. I mean, that's what, maybe huge things are there to explore. So, we are all in the journey and it's never a destination for all of us actually. But I feel humbled that I have been given, I studied in a place like Nirtar. I had great seniors, great teachers, and equally in Manipal. So wherever, but I feel that I tried my best to pick the best from those places. Maybe I could have picked more. So that is what is my take for all of you. Right? So how much time is left? Oh, I think time is up, but I'll see you definitely. I'll see you. Okay? So, I was given the time till 1. Saras bhai, sorry.
Sir, those patients coming with spondylolisthesis grade 3, having neurological deficit,
Yes.
how manual therapy helps?
I think best way, okay, we can try conservatively. Try it maybe maximum for 1 to 2 months. Conservatively, that this part already, this question I discussed, but still I will discuss once again. We can put, since it's the anterior slippage, maybe at L4 suppose we assume that it is at L4, okay, anterior slippage is there. We can put a pillow under the abdomen, okay, so that it is going on a principle of 3-point principal pressure. So then above L4, L5, now suppose L2 and L3, you can go for some transverse glides because already if this thing is there, pillow is there, some upward force is there, you give a transverse glide to the upper vertebrae and to the lower vertebrae, not to, you can please sit down, no, excuse me, you can sit down there where I am answering his query, please go in fast, you could have sit down, lot of space is there. Okay, so now suppose the L4 there is anterior slip, so now L1 and L2 upper vertebra, see if one segment there is hypermobility according to Fritz's law, above and below segment will be having stiffness. So upper vertebra you give the transverse glides, okay, to the lower vertebra also, not to the same level. No PA glides, only transverse glides so that some alignment correction can happen, can go for little bit of dural release, okay, and then go for the MET for anterior rotation dysfunction. Where is the model? Come. Lie down here, supine. Come to crook lying position, okay. Now we can go for this, forearm here ask the person to press it, take it for extension, press down. 1, 2, 3, 4, 5, 6. Okay, so this one we can apply. So this will be pulling the innominate posteriorly so that we will get a stretch. So this will also facilitate in the alignment. Okay, then we can go for the tapping techniques. Tapping we can apply. Okay, so try for maximum 1 or 2 months. Suppose you find improvement, that is fine. If it's not improving, then maybe next management, surgical management can be planned.
Thank you.
Why not?
With your permission, can
Yeah,
I
please,
have
please,
difference of opinion?
Yeah, fine, please.
So Dr. Mohanty has already given beautiful answer, and this is how you actually manage. But I will just pick the first line because you said there is a neurological deficit. So if there is a neurological deficit, the best thing is to first take, and patient is not going for surgery at all. So to save your skin, first thing I would suggest, tell the patient surgery is the right answer for you. Abhi Sanjay bhai was also saying कि हमारे पास भी grade 3 के बहुत सारे cases हैं और they are fine. Similarly, in clinic also, what Dr. Mohanty has said, I would totally agree with you. There are grade 3 and they are absolutely happy and moving around. But because youngsters are sitting, you should not carry away with the message that grade 3 is there and you can do the manual therapy. Grade 3 is there, make sure you first of all you save your skin and tell the patient that actually you are a case for the surgery and you must go and get the surgery done. Patient refuse for surgery, you say, okay, I'm ready to take you with the great precaution and do the consent paper. High risk consent paper gets signed. Okay. And then also, if it is a neurological deficit, in my personal opinion, I won't take that patient at all. Up to grade 1 is okay. Then in addition to that, I need to check the age of the patient. There are researches which says at the age of 80 plus, almost 50% people are having spondylolisthesis, non-traumatic. That could be because of the osteoporosis. So, but if the person is young and having grade 3, I won't play with his life. I will try to convince him for the surgery only. But if he says no, no way, then Mohanty sir has given beautiful answer, and this is how we treat, but with the great precaution. So this is basically a message for the youngster, and don't try to be God. Patient will make you feel like God, and it is okay till you feel like a God. So make sure not everyone walk in your clinic is a patient for you. You have to be very, very careful. Check the red flags always. And if patient is still stubborn, not want to go for surgery, Dr. Mohanty has given beautiful answer.
Yes, that is very, very, very important. I'll tell you, last month, just in continuation with Dr. Deepak sir's statement, somewhere somebody heard that somebody hip problem, go to Dr. Mohanty, you will correct it in Bangalore. I mean, from 100 kilometers that patient came, there is a femoral neck fracture. I saw the case, I told, see, let me tell you, whoever I told, that is a good thing they have done, but the best thing what you have to do is, did you visit an orthopedic son? Yes. Now 3 orthopedic son has told you to surgery. I told, see, you do one thing, I'll write in bond paper that you need surgery and go and get the surgery done to the best orthopedic surgeon. Because never we should take up the case, as I told you, that in such cases, patient is not ready. Patient definitely would have been told, he would have gone to surgeon and he has been told for surgery. Somewhere he has heard that without surgery you are doing some wonderful job, then they come and land with you. But then, as I told, I will strongly agree with Deepak sir, you have to tell that you are a case for surgery only. You want to take some try, we can take some try. If not, then you immediately go for surgery. That should be the fine thing. Okay. Madam, Joshni madam, you want to add something? Maybe something.
With a grade 3 listhesis patient. So I tried with like lumbar stabilization exercises. So, but the problem with such patients is that she doesn't want to go for surgery, but she is never satisfied. So वो भी एक प्रॉब्लम है, उसको भी डील करना पड़ेगा कि कैसे उसको सेटिस्फाई करना है कि शी लाइक बिकॉज क्लियरली आई हैड टोल्ड हर दैट यस यू आर अ केस फॉर सर्जरी, तो ठीक है स्ट्रेंथनिंग एक्सरसाइजेस पे गए थे एंड बट they will definitely have some symptoms, but now she's fine, now she's much better. That is my experience. Thank you
They
so
will ask
much.
sometimes which surgeon should I go. That also I am very careful. I tell, see, please select your surgeon, because the issue is surgery, once there is a knife goes, there are different equations are there. So suppose something wrong happened, patient will come and catch you, because of you I have gone to that surgeon and this thing. So I tell that please find out the best surgeon and you take your call. Correct? Fine. So thank you very much, organizers, especially to all my teachers, PP Mohanty sir, Mona madam, Nanda sir, Chitta sir, Tiga sir, and Dr. Binay is doing the great job, management, Dr. Bishwajit, all the organizing committee members, and it's a great pleasure to see all my seniors and to interact with so many of you. And I never believed that they will stick on to sit for so many hours in a talk, but I really appreciate all the back benchers and the middle one, front one. Thank you very much. Wish you all the very best. Thank you, the models. Okay?
Thank you, sir, for a session that took us from fundamentals to advanced clinical insights. Your clear demonstration transformed complex concepts into simpler and applicable understanding. The interactive nature of the session kept us deeply engaged throughout. Your words will always echo in our assessments. May I now request our chairperson, Dr. Narendra Behera sir, to give certificate to our speaker, Professor Dr. Umasankar Mohanty sir, as a mark of respect and appreciation.